So, Dr. Suresh, can you try sharing your PowerPoint?
Yes,
Dr.
sir.
Suresh? Yeah, please switch on your video. Yes, please share your PowerPoint. Please introduce yourself, your unit chief, your head of the department, and start your presentation. Good luck to you.
Yes, thanks.
Make it this into full screen, Dr. Suresh.
I see.
Starting with thank you.
Thanks.
No problem. Go to the first slide.
Good
Yes.
evening, ma'am.
Good luck to you.
Today I'm going to present. I'm Dr. Suresh, final year postgraduate from Tirunelveli Medical College, and I'm going to present the case presentation under the guidance of HOD Dr. Bhavita Devi ma'am and Chief Dr. Kamal Niviji ma'am. A 47-year-old male, manual traveler by occupation from Tirunelveli came with the complaints of ulcer over right upper limb since 4 months. History of present illness. The patient had previous accidental thermal burns over right upper limb at 10 years of age, for which he was treated in private hospital. Then the patient had itching over the burn scar site on and off for the past 1 year. Then he spontaneously developed ulcer over the burn scar site before 4 months. Initially, it was involving the elbow. Then the ulcer gradually progressed to involve the lower 1/3 of arm and upper 1/4 of the forearm. History of pain over the ulcer for past 3 months. Thrombing type of pain, no aggravating factor, cleared by medications. History of discharge from the ulcer present, which was bloody in nature, and sometimes it was associated with the purulent discharge. It was scanty in amount and not foul smelling. History of itching present over the ulcer. No history of fever, no history of trauma. No history of axillary swelling. History of restriction of movement present in the elbow since burns. No history of numbness, burning pain over the right upper limb. History of weight loss present. Past history, not a known case of diabetic hypertension, bronchial asthma, TB, epilepsy, CAD, and CKD. No history of similar complaints in the past. History of RTA 10 years back, he had a mandible fracture for which he underwent surgery. Personal history, mixed diet, normal bowel and bladder habits. Is a known smoker and alcoholic for the past 30 years. Is manual traveler by occupation. Family history, no significant family history.
Can you go to your first slide?
Yes, sir.
First slide here. You know, we have told so many times that it is not good to write a person a old one, okay? Right? So 47 years old male is not a good term. You can just say it's a 40-year gentleman.
Nice.
Okay, or manual laborer. Yeah, so that is old word is, no, it is okay that you are writing in terms of according to the age of that, but old usually means it should be more than at least 60 years.
Nice. Yes, sir.
Okay, right.
Yes, sir.
Then you are writing ulcer over right upper limb since 4 months.
Yes.
So since is also not a good word.
Yes, sir.
What should be here?
For 4 months.
Yeah, for 4 months. No? Yeah, rather since you exactly know from the day and time, no? That it is from there. So it is better to write down that it is for 4 months.
Yes.
Right. Go to the next slide. The patient had previous accidental thermal burn. Now, when you say it is a thermal burn, then you have to identify that what type of the thermal burn it was. There are many types of thermal burns which are there. So can you identify which type of the thermal burn was that? How did he get the burn?
He fell in the fire, sir. He was playing and he was fell nearby the fireworks was going, sir.
So was it a cracker burn or
No,
whether
sir.
a coal tar
Only
burn?
fire.
All
Fire.
these burns are very severe burns as compared to a ordinary fire burn which is there. If somebody has a cracker burn is there or the coal tar burn is there, they are much more severe than just a simple fire burn.
This simple fire burn, sir.
Yeah, so you have to write down about that, tell about that how did he got that?
Yes, sir.
And then he was treated in the private hospital.
Yes, sir.
Right. So was he admitted there?
Yes, sir. He was admitted and treated, sir.
Okay. And approximately, can you tell what was the percentage of the burn at that time?
He was involving only upper limb, sir. It's nearly 9 to 10%, sir.
9 to 10%. Okay. And then how long he was admitted to the hospital?
He was nearly for 1 week only, sir.
For 1 week. And what was done for him?
He was only cleaning and dressing only, sir. No flaps was given, no collagen dressing, anything done, sir.
Now, how do you know that what depth of the burn it is? Clinically, how do you know that?
He had a contracture, sir. Based on the contracture, depth will be.
Contracture will come quite later on. No? Immediately, how will you know what degree of the burn it is?
It is superficial. Once it will have blisters will be there, sir. It will be more painful.
Right.
And deeper burns, it will be scar tissues will be there, sir.
Yes. So, what type of the burn do you think this patient had?
Yes, third degree burns, sir.
Third degree burn, probably. Right. Okay. But then patient had itching over the burn scar site on and off.
Yes, sir.
Right. So, what are the causes of itching over a burn scar?
The fibro. Fibroblast depositions, increased fibroblast depositions.
Okay, tell what is the difference between a hypertrophic scar and a keloid?
There will be more.
Clinically, how do you say?
So, clinically,
hypertrophic scar or a keloid? Which is more itching?
Sir?
Itching is more present in hypertrophic scar or in the keloid?
Hypertrophic scar extends outside the scar, sir.
Hypertrophic scar, they extend outside.
Yes.
Or keloid, they extend outside.
Yes, sir.
Yes,
sir.
And itching, it will be more in keloid or in the hypertrophic scar?
It will be in keloids.
It will be much more in the keloid. No?
Yes, sir.
Then he spontaneously developed ulcer over the burn scar. So what are the causes of formation of an ulcer over a burn scar? What are the causes of ulceration over a burn scar?
There will be any trauma, maybe there, sir.
You know what is unstable scar? What is unstable scar?
Any trauma. Sir, there will be more further depositions.
What are the areas where you get more of the
unstable scar? There will be more collagen depositions.
At the
joints, sir.
At the joints, you know? If there is a scar at the joints there, then you are more likely to have the more of the unstable scar.
Yes, sir.
And if this ulcer persists, then what it is?
It is marginal ulcer, sir.
It's a marginal ulcer likely, right? So this patient had burned 10 years back and he has started developing the ulcer 4 months back, isn't it? Is that the
Yes.
usual time for ulceration? Is that the usual time for developing the ulceration?
No, sir.
No, this is okay. Okay.
Yes.
Ulcer may develop from months to years together, jo hai na? So anytime it can develop.
Yes.
So this history is okay.
Yes, sir.
That it has started only from 4 months
Yes, sir.
back. He started having the ulcer. But if he's developing the ulcer now,
Yes.
then will it be more like unstable scar or will it be more like a marginal ulcer?
It will be marginal ulcer, sir.
More like the marginal ulcer.
Marginal ulcer, sir.
Unstable scar, it will
Yes.
be in the early, na? So within months it will start.
Yes.
But once it is occurring
Yes,
after
sir.
9 years, so it is more likely to be that it is going to be a marginal ulcer. Okay.
Marginal ulcer.
Go to the next slide. Go to the next slide. Now, why he's having pain now for 3 months?
Next
What
slide,
is
sir.
for the pain?
The pain may be due to a secondary infection, sir, or it may be due to nerve infiltrations.
Usually in a scar area, all the nerves, they are burned, isn't it? So that area
This will be
becomes,
disturbed. Yes, sir.
it's like a more of an anesthetic patch is there. But why he's having the pain now?
Yes, sir.
Pain is because of?
Maybe due to secondary infection, sir. Or it
Okay.
may involve normal tissue, sir.
Yes.
Uh,
Getting
away from the
involved in
scar,
all
sir.
the normal tissue. Yes, that is
Yes,
very
sir.
important.
Yes, sir.
Okay. So, and it's a throbbing type of pain. What does the throbbing type of pain means?
Any infections, pus collections.
It is a pus collection is there. So maybe this patient had a pus collection in that area and that is why he's having the throbbing pain.
Yes, sir.
Okay. Then the history of discharge from the ulcer, which was bloody in nature, sometimes purulent, scanty. Okay. Why it should be bloody discharge?
It may be squamous cell carcinoma, sir. It be highly proliferant neovascularization will be there, sir.
So you think marginal ulcer is not a squamous cell carcinoma?
Sir. Yes, sir. Squamous cell
Is
carcinoma, sir.
marginal ulcer a squamous cell carcinoma or not?
Yes, sir.
It is a squamous cell carcinoma, isn't
Yes,
it?
sir.
But
Yes, sir.
usually, so what are the places from where you can have the marginal ulcer on a squamous cell on a body?
In previous scar sites, in venous ulcers,
Yeah.
in chronic discharging sinuses.
Yes. Yes, tell the other reasons, other places or other reasons for the marginal ulcer.
In
One, you said the burn scar. You said
yes,
the
sir.
venous ulcer.
Yes. Chronic discharging sinus or osteomyelitis, sir.
It's
Then
osteomyelitis.
it may
Right.
occur in lupus vulgaris also. Yes, sir.
Yes. Okay. Can in a fistula in ano you can get a marginal ulcer? Fistula in ano? You can get it there also.
Yes, sir.
So any chronic discharging sinuses which is there can have the marginal ulcer. Okay.
Yes, sir.
History of itching present, no history of fever, no history of trauma. There is a definite history of trauma is there. Do you think trauma is only by beating something? Is thermal not a trauma?
Yes, trauma. Yes,
So
trauma
don't
only.
say it is no history of trauma there. There is a definite
Yes.
history of trauma. Thermal burn is there. That is a trauma.
Yes, sir.
Okay. Right. Go to the next slide. No history of axillary swelling. Why? Why did you ask about the axillary swelling?
In squamous cell carcinoma, there will be lymph nodes metastasis, sir. In Maudolian cell, sir, obviously it not be there, sir. If it involves the normal skin, there may be lymph node metastasis, sir. In secondary infection also, lymphadenitis will be there, sir.
All right. Okay, that's fine. Yeah. History of restriction of movement present in elbow since burns. So, what are the restrictions the patient has? What the patient says?
Is unable to extend the elbow, sir. Partially extends the elbow, sir. Able to flex, he can't extend the elbow, sir.
Is he able to take the food with that hand?
Yes, sir. With mild difficulty, he is able to take, sir.
He is able to take that. Yeah.
He is able to take food, sir.
Okay, but he's not able to extend the elbows. Yeah?
Yes, sir. Partially he can extend. Cannot extend to the full range of movement, sir.
All right. No history of numbness, burning pain over right upper limb. Why?
If any nerve infiltrations, distal limb will have a burning pains, numbness, anything will be there, sir.
Now we said that the nerves, they are burned in the cases of burn.
Yes.
So what can be the cause for the, if numbness pain is there? What happens to the cut ends or burned end of the nerves here?
Neuroma.
Yes, neuroma formations are there.
Neuroma formation will be there, sir.
Right. So because of those neuroma formations, the patient can have the numbness and the burning pain is there. Okay. History of weight loss present.
Yes.
Do you think this patient will have the weight loss? A patient of a marginal ulcer of the elbow will have the weight loss?
No, obviously, sir.
How much is the weight loss in this patient?
Sir, initially he was 70 kg nearly, sir. Now he was only 55 to 60 only, sir.
Okay, so there is a significant weight loss is there.
Yes, sir.
What is the significant weight loss?
More than 10% of the body weight in 3 months, sir.
Okay. Right. Okay, go to the next slide. Now, why all these history? Not a known case of diabetes, hypertension, bronchial asthma, TB, epilepsy, CAD, CKD.
In diabetic infections will be more, sir. In hypertension, if we are planning for any surgeries, pre-op evaluations we are needed for this history, sir.
Okay. And why the epilepsy?
In pre-op evaluations we need, sir. If we had any epilepsy, pre-op evaluation.
Pre-op evaluation. Okay.
Patients, sir. If you are any planning for any surgeries.
No history of similar complaints in the past. Why that history?
If he has any previous history of same illness, is again to develop the same, sir.
And then at the same time, 10 years back, when he had this burn, he also had the fracture of the mandible. It was the same event or it was different event?
It was different event, sir.
Burn occurred differently and this fracture was differently, is it?
Yes, sir.
Okay. And he does not have any problem in the mouth?
No, sir. No, sir. He's able to open the mouth. In that scar site, no ulcers, no keloids, no hypertrophic scars.
Okay. Go to the next slide. Okay. Mixed diet, normal bowel and bladder habits, no smoker and alcoholic for 30 years, and coolie by occupation. Now, is mixed diet and the normal bowel and bladder habits are going to make any difference in this patient? Okay, just for the history sake, you ask about that.
Yes.
Passage probably there'll be not much.
Yes, sir.
Smoker and alcoholic?
Yes, sir. Yes. Smoker and alcoholics leads to one of the risk factor for squamous cell carcinoma, sir. For carcinoma, sir.
Okay. And how does it is going to make a difference in the treatment of this patient? If a patient is a smoker,
Yes, sir.
and this is your patient,
Yes, sir.
for planning the treatment, does the smoking can change your plan of treatment?
No, sir. No, sir.
No, if there's somebody has got is a smoker is there, and you
Yes, sir.
want to put a flap on that, skin flap.
Yes, sir.
Does the smoking make any difference?
Yes, sir. It causes collagen.
So if you're planning for the skin flap, then you have to have a very good vascularized flap in this.
Yes, sir.
Okay. But
Yes,
if
sir.
you are taking a flap which does not have much of the vascularity,
Yes, sir.
this flap will not be taken. And that is why smoking will be a part of the treatment plan in this patient. You know, that is you have to ask the patient to stop the smoking if you're going to put a flap in this patient. Okay.
Yes, sir.
All right. Coolie by occupation, how does that make a difference?
It's more exposure to sun radiation, sir. UV radiations. It may predispose to squamous cell carcinoma, sir.
Yes. And from the treatment point of view, he is a coolie by occupation. So he has to lift the heavy weights.
It lifts a heavy weight, not cancer.
So if he's lifting the heavy weight from the same place, from the same hand, always there will be movement at the elbow will be there.
Yes, sir.
So it will be so difficult to stabilize that.
Yes, sir.
Until unless he's doing only from the other hand.
Yes, sir.
But if it is also working from the same hand, then it will be, and probably that may be one of the reasons that why this patient had a unstable scar or the ulceration was there because the repeated pause movement of the elbow leading to the ulceration and ultimately to the margin. So this may be one of the precipitating cause also for.
Yes,
So
sir.
occupation will be the precipitating cause in this patient for the margin ulcer. Next slide. Next slide. No significant family history. Why did you ask about that? Family history? Does the cutaneous malignancies they run in family?
No, sir.
No, they can run. Cutaneous malignancies can run in families also.
Yes, sir.
Okay that you asked about that. All right. If any other examiner there? Hello? If anyone else is there, Dr. Kanagabal?
Sir, I'm waiting for them to join, sir. What
Okay.
time you need to leave, sir?
No, I will continue with that. I will continue.
Yes, sir. Please go ahead, sir. Please go ahead, sir. Because
Yeah.
Hitesh, I'm myself are coordinating with that. If
Uh-huh.
not, we will be able to run, sir. Please continue that.
Okay, okay, right.
Thank you, sir.
Okay, Suresh, go on the examination.
Yes, sir. On examination, the patient conscious oriented, moderately built and nourished, febrile, hydration fair, pallor present, not eating, no cyanosis, no clubbing, no generalized sleep fatigability. White upper limb, pulse rate 82 per minute, temperature febrile, respiratory rate 16 per minute. Examination of the right upper limb. So the clinical picture of the patient. Inspection, single ulcerous lesion of size 18 cross 15 centimeter involving the medial aspect of lower 1/3 of the arm, elbow, and upper 1/3 of the forearm. Irregular in shape, extend anteriorly medial to apex of the cubital fossa, posteriorly medial to the oligranum process, proximally up to 8 centimeter proximal to the oligranum process, distally up to 7 centimeter distal to the oligranum process.
Okay, go ahead.
Ulcer was very defined, irregular margin with everted edges. The floors covered with unhealthy granulation tissue with uneven surface with percent rural discharge. The surrounding skin, in the surrounding skin, patchy areas of hypopigmentation with the scar present. On palpation, the inspected findings of size, shape, and extent confirmed. Ulcer not mobile, base indurated. The plane of the swelling present over the bone. Ulcer bleeds untouched. Surrounding skin not indurated. Scar present, not warmth, not detected. Regional lymph nodes, no enlarged axillary nodes, no other nodes palpable. On other examination, the extensor movement at right elbow is restricted. Other movements of the upper limb are intact. Wasting noted in the right upper limb compared to the left. Temperature and sensations are intact. Left upper limb appears normal. Systemic examination, cardiovascular system, S1, S2 present, no murmur. RS, bilateral air entry present, no added sounds. On abdomen examination, soft, non-tender, no mass palpable, no organomegaly. Central nervous system, no focal neurological deficit.
Okay, Suresh, can you go to your first examination slide? Go to the first slide. Okay. What do you understand by generalized lymphadenopathy? What is the meaning of generalized lymphadenopathy?
3 or more contiguous lymph nodes.
How many?
3 or more contiguous lymph nodes.
3. Is it 3 or it is? And they are contiguous or they are non-contiguous?
Contiguous.
2 or more, not 3.
Yes, sir. Yes, sir.
Like if somebody has got a cervical lymphadenopathy and the axial lymphadenopathy, then that is a non-contiguous variety.
Yes.
Is 2 or more non-contiguous type of the lymph nodes, that is labeled as a generalized lymphadenopathy. How did you check for the hydration of this patient?
Seeing tongue and skin, pinching the skins. Sir, on pinching the skin, sir.
Yes. So the patient is emaciated?
No, sir. It's moderately built and nourished.
So how will you differentiate between emaciated skin and a non-hydrated skin?
Skin turn. Skin turn, sir.
You will always check for the tongue of the patient.
Yes.
Okay. In both cases, when you pinch the skin, it will go slowly, whether the patient is hydration or the patient is having the emaciation. But then you check for the tongue of the patient and see if the tongue is moist or not.
Yes, sir.
Okay, the tongue is moist, then the patient is hydrated. Hydration is good. But he may be emaciated there.
Yes, sir.
Okay. All right. Go to the next slide. Why did you write family history here?
Vital, sir. Mistaken, sir.
Wrong, mistaken. Okay. Now, in the pulse rate, you have written 82 per minute. You want to elaborate this pulse rate?
It is palpated equally on both upper limbs, sir. Normal volume.
And one more thing has to, what is the age of the patient?
Sir, 47 years, sir.
Okay, so relatively, you have to tell something more in the pulse. Apart from telling about the rate, you have to tell about the rhythm of the pulse,
Yes, sir.
Is that important? What are the various types of rhythm of the pulse?
Yes, sir.
What are the various types?
Regular rhythm, irregular rhythm, irregularly irregular,
It may be regular or it can be irregular.
irregular, sir.
And in the irregular, what type are there? In the irregular rhythm,
Sinus
what are
rhythms.
the various types?
In rhythm, sinus rhythm, sir.
What are the two types of the irregular pulse?
Regularly irregular, irregularly irregular, sir.
Okay. Right. Temperature afebrile, respiration rate 16. Okay, go to the next slide. Right. Now, it is always good whenever there are two parts, there are two upper limbs are there, two lower limbs are there. Always better to mention about the other limb first, which is the normal one. Okay, that is customary.
I see.
So in this patient, you will say that the left upper limb is apparently normal. And
Yes.
then you will start telling us about the right upper limb.
Yes.
Okay. Okay, go to your next slide. Go to the next slide. Right. Now tell about that. Attitude, elbow is partially flexed and forearm in supination position. What is happening to the wrist joint? Go back to your clinical photograph. Go back to the clinical photograph. Do you have a photograph of the wrist joint?
Yes.
Yeah. See what is happening there? Something wrong there or it's normal? Or the patient is keeping like that?
Keeping that only. He's able to do all movements.
He's able to do all the movements at the wrist joint.
I see.
Okay. Now tell about the elbow. What are the abnormalities in the elbow joint?
Elbow is partially flexed. It is in a supination position, sir.
Yes. So how much is the flexion deformity here? How will you measure that? How will you measure the flexion deformity?
Horizontal plane, sir. From horizontal plane, it is you have a dry horizontal plane from the elbow, sir.
So how much do you think in this patient is the flexion deformity?
30 degree, 30 to 45 degree.
30 to 45 degree. Okay, right. Okay, go to the next slide again. Go to the next slide. Yes. A single, okay, the spelling is not correct, है ना? Okay, ulceroproliferative. Lesion of 18 by 15 centimeter involving the, which part of that?
Medial aspect of
The medial aspect of lower 1/4 of the arm, elbow and upper 1/4 of the forearm. Okay, irregular in shape, extent medial to apex of cubital fossa. What is that?
apex anteriorly cubital fossa, sir. Apex is formed by brachial radius and pointed radius, sir.
So are you able to
It is
find out?
just medial to the apex of the cubital fossa. Simply, man.
Just go back again to that. So can you, with your pointer, can you make where is the cubital fossa? Can you, with your pointer, you can show the cubital fossa where it is?
Sir.
Yeah. So, but your ulcer is extending right at least 5 centimeter above that, isn't it?
Yes, sir.
Proximal side?
Proximal side, it is it organ process with this.
Okay. Right.
Organ processor. Only from proximally, it is 8 centimeter from the organ processor, and distally it is 7 centimeter from the organ processor.
Right. Okay. Okay. Go to your slide. Right. Go to the next slide. well-defined irregular margins. What is the difference between an edge and a margin?
Margin is formed by normal tissue and the edges, sir. Edge is formed from the margin to the floor of the ulcer, sir.
Which is medial, which is lateral?
Edges is medial, sir.
Okay, right. So in your patient, well-defined irregular margins. Usually margin is a palpatory finding or it's an inspectory finding?
Inspectory findings.
No, margin is a palpatory finding, you know? Because you say that margin is indurated.
Yes, sir.
It is formin, you know? So it is usually a palpatory finding. While
Yes.
edge you see
Yes.
that it is inverted or everted or punched out or whatever it is. No? Okay. Go to the next slide. Yeah. Next slide. Yes. Floor covered with unhealthy granulation tissue with uneven surface with pus and bloody discharge. Surrounding skin patchy areas of hypopigmentation with scar are present. All right. Now, what are the various types of granulation tissues which can occur over the floor?
Blood granulation tissue, sir.
Yes.
In healing ulcer, there will be red granulation tissue, sir.
Yes.
In non-healing ulcer, there will be unhealthy pale granulation tissues will be there, sir.
So this type of the ulcer which is there, in which group this ulcer will come?
Come in chronic ulcer, sir.
Chronic ulcer. So what do you understand by chronic ulcer?
Chronic.
How do you define a chronic ulcer?
Ulcer presenting for more than 3 months, sir.
Ulcer which is present for more than 3 months.
Yes.
Some people also say 6 weeks also. Some people say 3 months.
Yes.
Okay, both the, yes, are correct, you know? Okay.
Yes, sir.
Okay, go to the next one. Next one. Right. Tell about that.
Inspectory findings of size, shape, and extent confirmed. Ulcer, which is not mobile, base is indurated, the base fixed to the bone, sir. Bleeds on touch. Surrounding skin not indurated, scar present, not warmth and non-tender.
How do you say the plane of the ulcer is over the bone?
The ulcer is not mobile, sir.
Mhm.
Even on relaxing the muscles.
Is such a big ulcer is there, you know?
Yes.
And the amount of the soft tissue is so less there.
Yes.
So there will be hardly any movement of the ulcer will be there. Even if
Yes.
it is not directly fixed to the bone,
Yes.
not much of the movement of the ulcer will be there.
Yes.
So it is very difficult to say that it is over the bone, you know?
Yes.
Right? Right. Go to the next slide. No enlarged axillary nodes. Can other nodes be involved in this patient apart from the axillary nodes?
Epithelial nodes will be involved, sir.
Yes. So you have to tell about that, those also, Jay.
Yes.
Right? That. Okay, next slide. Have you tested the neurovascular sensations here in this patient?
Yes, sir.
Vascular, have you tested anywhere? Have you
Yes,
mentioned?
sir.
Where have you
Temperature
mentioned about the vessels here?
Sir, since I was mentioned in the ulcer, I not returned here, sir. I mentioned it in the vital, sir, so that I not returned here, sir.
But you don't think it should be mentioned here also? It is such
Yes, sir,
important.
you have to mention, sir.
You have to mention. And are you only interested in the radial artery here?
No, sir, radial ulnar.
Yes. Have you mentioned about the ulnar artery here?
No, sir.
Where do you feel the radial artery?
For the radial striatal process, sir.
Hmm?
Over the radial striatal process, sir. For the
Lower end of the
radius,
radius, is it?
sir.
Where do you feel it?
over the radius styloid process of the radius.
I'm not sure. Are you correct in that? And ulnar artery?
Over the styloid process of the ulna, lower end of the ulna, sir.
Lower end of the ulna there. Right.
Yes, sir.
Okay. Okay. Have you tested the wasting? You have written wasted noted in the right upper limb compared to the left.
Yes,
How
sir.
do you check for that?
You have to measure the mid-arm circumference.
Have you measured that?
Yes, sir.
But you have not written anywhere. You have to write down, and if you have measured that, and if there's a difference is there, you have to
Yes,
tell us about that.
Yes, sir.
Okay. Right. Go to the next slide. Right. Systemic examination is okay. So go to your diagnosis. Will you like to keep any differential diagnosis here?
And chronic ulcers, sir. Chronic non-killing
What are
ulcers.
the other malignancies which can occur over a chronic scar, apart from the margins ulcer? Can any other malignancies can occur over the scars?
No, sir.
Do you know any sarcomas? Sarcomas can develop over the
Yes, sir.
chronic scar. No?
Yes, sir.
Like if somebody has got the repeated cesarean section is there,
Yes, sir.
and there's a scar is there, and over that a malignancy develops. What is that malignancy? Any idea? Over a Caesar scar on the abdominal wall.
Fibrosarcomas.
Okay. So what is that called as?
Fibrosarcomas, sir.
You know any name of that? Desmoid tumor, have you heard?
Yes, sir.
Desmoid tumors, no?
Yes, sir.
Okay. So apart from, though in this patient, probably there is no other differential diagnosis, but just for the sake of discussion, you may keep the sarcomas as a differential diagnosis. No?
Yes, sir.
Okay. So how you are going to proceed with it?
To confirm my diagnosis, I'm going to take a edge-wedge biopsy, sir.
Okay. And
Then I have to take MRI to see the level of the.
from where you would take a biopsy?
And from edge of the ulcer, sir.
Why edge of the ulcer?
There will be more proliferation over the edges will be there, sir.
Okay. And any other reason that you take it from the edge?
It will involve the normal tissue also, sir.
Yes, it will have the normal tissue also. So you can compare with that.
Yes, sir.
And you can see the lot of the mitotic activity in that. That is the spreading area.
Yes, sir.
So a lot of mitotic activity may be there.
Yes, sir.
Okay. So what do you expect in this patient, the biopsy report?
We'll expect well-differentiated squamous cell carcinoma, sir.
Okay. And how the pathologist will say it is a squamous cell carcinoma?
Keratin pearls will be there, sir.
Okay. All right. Oh. Any other investigation you want to do?
I will do a MRI to see the depth of the plane that the tumor infiltrates, sir.
So before you go for the MRI of that, if the patient says that I cannot afford the MRI, and you are saying this plane of this swelling is at the bone, so can you do something very simple?
X-ray we can do,
Decide
sir.
your treatment.
X-ray we can do.
Yes, just do a simple X-ray here.
Yes, sir.
Okay.
Yes, sir.
Yeah, if the X-ray shows that there is involvement of the bone is there, then the treatment plan is totally different.
Yes, sir.
Okay. Has it been done in this patient?
X-ray done, sir.
Okay, can you show that?
Not attached.
Not attached?
Yes.
Okay.
Suresh, you can unshare this PPT and show the slides if you have in the picture. You have in your system?
No, sir.
Okay.
You don't have access. Do you have access to the images or not?
Sir, I'm not having the system, sir.
Okay.
Do you have
You
the
have to-
MRI?
Yes, sir,
MRI of
please.
the patient?
The MRI hands. Report
Okay,
alone
show
hands,
that.
sir.
Okay, show that here. Okay, what does it show? Read
It's,
that, read the report. And if you have a picture, show that picture also.
yes, sir. It's a
You don't have a picture? Okay.
Yes, sir.
Okay, read the finding.
Approximately 16.6 plus 6.5 plus 2.5 centimeter sized T1 hypoindence, T2 hyperindence, exophytic lesions noted in the posterior medial aspect of the lower one-third of the arm and upper one-third of the forearm. The laser infiltrates into the subcutaneous tissue and triceps muscles just above the elbow joints. Approximately 1.5 cross 1 centimeter sized adjacent lymph nodes noted in the subcutaneous of lower arm, sir.
Mhm. Does it tell about the vascular, neurovascular structures here? Do they
No,
mention
sir.
anything about the neurovascular?
No, sir, they are mentioned.
They are not mentioned?
Yes, sir.
Okay. But did you discuss about this MRI with your
Yes,
radiologist?
sir. We discussed it, sir.
And did you ask about that or not?
Yes, we asked her. There was no infiltration, sir.
The neurovascular bundle was intact here.
Yes, sir.
Okay, the brachial artery was not involved in that. No?
Yes.
Okay. Any other investigation you have done? Any other investigation you have done? Okay. It's a well-differentiated squamous cell carcinoma.
Yes, sir.
All right. And they are mentioning something about the lymph nodes, isn't it? Which lymph nodes they are mentioning? In the MRI, they said some lymph nodes are there, isn't it?
Yes, sir. They have mentioned epithelial nodes.
But not the axillary one, is it?
Yes, sir.
Have they looked into the axillary nodes there in the MRI?
No, sir.
They're not looking at the axilla here, no?
Yes, sir.
I think that should also have been seen in this patient, no?
Yes, sir.
Which they have not mentioned there. Okay. Any other investigations you have done? Any other investigation for this patient?
Dopplers and ultrasounds of axilla we did, sir.
Doppler.
Yes, sir.
Which Doppler you have done? For?
Heterogeneous of upper limb, sir.
Why you want to do a Doppler in this patient? The purpose of that?
Any thrombus in the veins, sir.
But you say the radial artery is well palpable, ulnar artery is well palpable. There is no feature of ischemia there in the hands are there.
In veins, it may be any infiltrations, any thrombus.
So if you think if the vein is thrombosed,
Yes.
his limb will look like that? Or will there be the venous edema or lymphedema will be there?
Yes, sir.
That is not there in this patient.
Yes.
Okay. So probably, but it's okay that you have done that, but it is not required for this patient to carry out that. Okay. You do not want to rule any metastasis here?
We have to take a CCD test, sir.
Yeah. No, even if you not do the CT of the chest, at least X-ray of the chest.
X-ray of the chest. Yes, sir.
Can a margin ulcer or squamous cell carcinoma metastasize to the lungs?
Rarely it will metastasis, sir.
Yeah. How much is that rarity? Around 10%.
Yes, sir.
Okay, 10% can metastasize to the lungs. You know? So that is why you have to have the X-ray of that. Okay. Right. So with all these reports which are there, has something been done for this patient or not?
We can do wide log lixation, sir.
Now, before you go for that, where this patient should be discussed?
It should be discussed in tumor board, sir.
Yeah, this patient has to be discussed in the tumor board to plan for the treatment in this patient.
Yes, sir.
Okay. So, has it been discussed in the tumor board?
Still not yet discussed.
Okay. Something has been done for this patient or not? If
Yes,
some
sir.
intervention has been done in this patient or not?
No, sir, not.
Not done. Okay. So, what is the plan?
Yeah, plan for wide log lixation, sir.
Okay. So, when you do the wide local excision, do you think then you can get the R0 margin here?
Yes, sir, we can get.
No, this is sitting right over the all vital vessels there, is it? So probably you may not be able to get, but a very minimal margin may be there in that.
Yes, sir.
So you're right that you will go for the wide local excision for this patient.
Yes, sir.
And then how you're going to cover that?
With the flaps, sir.
So from where you will get the flap in this area?
From pectoralis. Pectoralis flap, sir.
The pectoral flap will come in that area. You have to take the arm to that area. Now you can do that.
Yes, sir.
But you have to take the arm to that area. And that flap will not come here, but you have to take the arm to the pectoral area. And
Yes,
then
sir.
you can put the flap there.
Yes.
Any other better option which may be there? Can you take a free flap here? You can opt also for the free flap in this patient.
Yes.
Right? That is one possibility which is there. Okay. Will you like to have in this patient some neoadjuvant treatment before you plan for the surgery?
Marginal, sir, mostly chemo resistant, sir.
Yes. Why they are chemo resistant? What is the reason? Why the squamous cell carcinoma are chemo resistant and radio resistant also, and both?
Yes. Yes, sir, it is.
Yeah, because everything has been burned there, so there is hardly any vascularities there, lymphatics are burned. So all those things which are burned in that area, and that is why
Yes.
they are quite chemo and the radio resistant. So in this patient, your first choice should be to go for a wide local excision and cover of that area. But
Yes.
maybe that this patient, when you go, you will find that it is involving the periosteum there. So if there's a recurrence is there, then in that case, you have to go for the amputation in this patient. And then you have to also see for the axillary nodes which is there, whether if the axillary nodes are there, then you have to check for that also. And you have to do the axillary block dissection along with the wide excision.
Yes.
So you have to also, it's quite a large tumor which is there. Dr. Kanagal, can we? Dr. Kanagal, can you stop here? Or if
Yes,
somebody,
sir. I think if he has any doubts, he can clarify.
yeah.
Then we'll move to the next case, sir. Sir, Suresh actually was given a very short time, sir. Actually, someone withdrew from the because the candidate was sick. So Suresh was hardly given less than 1 day time to prepare for the thing, sir. So this patient was recently admitted to the ward. The HOD madam told me. So still they have not worked up this case up to the level of MDT, sir.
Okay.
MDT is planned and then later only they are planning for treatment.
Right.
I think they are more of consideration towards above elbow amputation. So that was the discussion which is happening at this point of time.
Right.
Considering the situation, they want to consider that.
Right.
Anyway, Tirunelveli Medical College, the government medical college there has a robust presence of oncoplastic team also. So after MDT, probably next week, we will share the information. Sir, Madam updated me. Suresh, do you have any questions now that you are prepared for this presentation? Do you have any comments or questions you would like to clarify from the examiners here? Thank you, Dr. Suresh. Thank you for joining us this evening. Kamalin, madam, are you with us?
Yes, sir.
Madam, would you like to give any comments, madam? Kamalin,
No,
madam
sir.
is one of the unit chiefs, sir, at the same medical college. HOD madam is in travel, so madam has deputed Kamalin madam to come in for this class. Any questions from your side, ma'am, or any comments from your side?
My student.
Yes, madam.
Yeah.
Thank you. Thank you.
Yeah, Suresh has done well. Yeah, Suresh
Thanks.
has done well. Yeah.
Thank you. Thank you, Suresh. You stay with us. Smith, can you share your PowerPoint and start your presentation? Kanna sir, you let me know whenever you have your meeting, you please inform and leave. Sir. Till then, we'll keep going with this. Sir.
Okay. If
Yes,
any other examiners are there or not?
No, sir. I think Hitesh Andaria is team. Actually, he has only taken the examiners for this week, sir. Two of them are from Shamrao Medical College at Nashik and one from Bangalore. Looks like they are finding difficult to join. I've asked Professor Marthupandian sir to join, sir. He'll be joining in another 2 to 3 minutes, sir. He is just reaching home, he said. So till then, we'll keep going, sir.
Right, okay.
Dr. Smith, please introduce. Yes. Dr. Smith is kindly contributed by Professor Pankaj Modi, sir, from BJ Medical College, Ahmedabad. So, Dr. Smith, can you introduce yourself, your unit chief, and then head of the department and start your presentation?
Yes, sir. So I am a General Surgeon Resident from the BJ Medical College, Ahmedabad, under Dr. Pankaj Modi, sir. My head of unit is Apurva Shah, sir, and Dr. Vineet Chauhan, sir. Hello. Can I audible, sir?
Yeah, you are good and audible, ma'am.
Yes, thank you, sir. I am presenting the case presentation on thyrotoxicosis. A 62-year-old male patient residing at the rural Mehsana, laborer, and belonging to the lower socioeconomic class presented in OPD with complaint of weight loss 1.5 years ago, increase in stool frequency 1.5 years ago, swelling in the neck since last 1.5 years, difficulty in the closing eyelids while sleeping since 1 year, and redness in the eyes since 1 year. Patient was asymptomatic before 1.5 years. Then he noticed the weight loss of 15 kg in 4 months associated with the increased stool frequency 10 to 12 episodes per day for 1 week. Then he consulted to physician where he incidentally noticed a swelling on the right side of the neck and got medication after the blood reports get done. And patient on regular follow-up, dose of the medication were increased. Swelling was initially smaller in size and gradually increased in size involving the both sides of the neck. After medication, patient gained the weight and no weight loss since last 5 months. Patient is also having difficulty in the closing and eyelids while sleeping, which was progressively increased and associated with the redness in eyes since last 1 year. He referred to civil hospital with the same medication, not associated with the pain or fever. No history of sudden change in the size of swelling. No history of any other swelling in the neck. No complaint of diarrhea, weight loss at present. No complaint of palpitation, breathlessness or vision problem. No complaint of excessive sweating or intolerance to heat or tremors and weakness. No complaint of dyspnea, dysphagia or change in the voice. Patient is not a known case of diabetes or hypertension. Patient having no past history of TB or any other major medical or surgical illness or blood transfusion. No history of any other medication or not a known allergy. No significant family history. Patient is vegetarian by diet. Bladder and bowel habits are unaltered at present. Sleep is normal. Appetite is normal. Patient having addiction of BD smoker, 1 bundle a day since last 20 years. a 62-year-old male patient presented with a complaint of weight loss 1.5 years ago, associated with the watery diarrhea 1.5 years ago, with incidentally noticed the neck swelling since last 1.5 years, which was gradually increased in size and becomes current size, and also having difficulty in closing eyelids while sleeping, with redness in the eyes since last 1 year. Patient got medication from the private hospital after blood reports, and after starting medication, patient symptoms improved. However, dose of medication increased 2 times in the follow-up.
Bharata sir, good
That's the
evening, sir.
lesson.
No, please wait. Go to the first slide.
Yes, sir.
Bharata sir, please take over, sir.
Yeah. So weight loss is there, huh?
Yes, sir.
How much he has lost?
Sir, he has lost 15 kilogram in 4 months of duration.
Okay. Go ahead.
Go to the next slide. Dr. Smith, will the patient be able to tell all this information? It looks like fairly all these, the swelling symptoms all began at the same time. Am I getting it right?
Yes, sir. He has, sir, initially, sir, weight loss as a symptom, and when he has increase in stool frequency, then he get consulted to the physician, sir. Sir, neck
Okay.
swelling is not present, the patient's complaint, which was noticed by physician, sir.
Okay. 1 minute. Professor Sanjay Kumar, sir. Thank you, sir. Thank you for joining.
Good evening, sir. Good evening.
Sorry for pulling out this odd time.
My pleasure, sir. No issues.
We just started the presentation, sir. We have
Right,
Professor
right, sir.
Madhupandian, sir, also on the forum. Kanna, sir, is there with us. And he has just started the presentation, sir. This case is presented with loose motions, weight loss, and a swelling over the front of the neck for 1.5 year duration. 15 kilos weight loss in the last 4 months, sir. That is the background of this case, sir. Go to the next slide, Dr. Smith. Could you tell what is the medication he had, Dr. Smith, for this?
Sir, he was taking, sir, neomarcazole, sir.
Okay, what is the dose?
He was taking, sir, 10 mg dose, sir, TDS, sir.
TDS. Okay, how many months he has been on neomarcazole?
Sir, he was started medication, sir, when he was diagnosed 1.5 years ago, sir. Initially, it was lower dose, sir, and then the dose is increasing 2 times, sir, in
Okay,
this period.
so now, according to you, patient is still on neomarcazole and still he has started getting newer symptoms. Am I getting it right?
Yes, sir.
So he's still on neomarcazole.
Yes, at the presentation at our OPD, he was on the when he was present, he was on the neomarcazole 10 mg TDS.
Okay.
TDS dose.
Can I ask you one question? A patient who has been doing well, responding to neomarcazole, probably they would have titrated the neomarcazole with few tests of thyroids and others. So if you have a problem of non-response to neomarcazole, what are the things you will consider in this patient? Which was responding almost now 14, 15 months. Last 5 months only it is not working. Am I getting it right?
Yes, sir.
So, what are the potential reasons a patient who was so well responding has gone out of medical control?
Sir, probability, it can be, sir, due to, sir, if in between, if a patient get lost to follow, but sir, he don't give any history like that, sir. Or maybe, sir, it can, sir, the dose is not sufficient to, sir, suppress the symptoms as the disease aggravates, sir.
Okay, what is the maximum dose of neomarcazole you can consider as the upper end of the dose?
Sir, it can given up to 40 mg dose in TDS, 20 to 40 mg TD.
No. Up till 60 milligram per day, if it is not responding, then you have to consider adding a drug or rework the patient up. Can you quickly tell, like now that we are narrowing to autoimmune thyroiditis, what is the biology of the autoimmune and where exactly the neomycosal works on the disease process?
Sir, it acts
What
on
goes
the
wrong in normally?
Sir, it acts on the inhibition of thyroid enzyme, thyroid peroxidase enzyme, sir.
What is
And
what exactly goes wrong in Graves' disease?
in Graves' disease, it is autoimmune condition. There is a thyroid thyroid receptor TSH receptor autoantibodies, which is doing sir continuous stimulation of thyroid receptor, sir. So there is overproduction of thyroid hormones.
Marutu sir, Sanjeev sir, please take over, sir.
Sumit, with the history and your presentation as of now, what are the possibilities you'll think of? Diarrhea, loss of weight, neck swelling.
एक मिनट बिडास
Sir, it is when there is a neck swelling associated with a diarrhea and that weight loss, sir, we can suspect the hyperthyroid condition in the patient, sir.
Anything else?
Uh,
Can you think of any other syndromes?
syndromes like
Swelling, you are thinking only in favor of thyroid alone.
medullary carcinoma, thyroid.
yes sir.
What are the other possibilities you'll think of? Pheochromocytoma, this.
Yes, sir. Mann syndrome.
Will you have this?
Yes, sir. In the Mann syndrome, sir, there is a parathyroidism, sir, and pituitary adenoma, as well as sir, pancreatic tumors, sir.
Yeah, there are different men syndromes. MEN type 2.
Yes, sir. This is Mann 1 syndrome, sir. Then Mann 2, in the Mann 2 syndromes, there is a sir medullary carcinoma thyroid, sir. Then the M222.
Marfanoid.
Marfanoid features, yes, sir. Marfanoid feature and pituitary adenoma. Another is hyperparathyroidism. Sir.
No, I don't think.
Paragangliomas, sir.
Paragangliomas, yes.
Yes, paragangliomas.
Okay. What's the clinical examination finding? Tell me.
Sir, on general examination, after taking the informed consent, I have examined my patient in adequate light and exposures. Patient is conscious, oriented to time, place, person, and cooperative. Average built and nourished. BMI is 23 with weight of 59 kg and height is 160 centimeter. Temperature is normal. Pulse is 80 beats per minute with regular rhythm and normal volume in the right radial artery. Sleeping pulse is 74 beats per minute with regular rhythm and normal volume in the right radial artery. Blood pressure is 140 by 90 millimeter mercury in right brachial artery in sitting position. Tremor is not present. No pallor, icterus, cyanosis, edema, clubbing or lymphadenopathy. Sir, this is the clinical photograph of our patient, sir. On inspection, sir, I have examined the patient with proper light and exposure. Approximate 15 by 10 centimeter butterfly shaped diffuse swelling present in the front of the neck, with surface is smooth, margins well defined, inferior border is visible, overlying skin normal, no scar or sinus over the swelling. Swelling moves with the deglutition, no dilated veins over the neck and chest wall, no other visible swelling in the neck present. On ophthalmic examination, there is wide palpebral fissure with upper eyelid retraction and infrequent blink with a stare look present. On palpation, Our inspectory findings are confirmed by the palpation. Approximate 15 by 10 centimeter butterfly shaped diffuse well-defined swelling with smooth surface in front of the neck, with temperature normal, non-tender, consistency is soft to firm, overlying skin is normal, with horizontal extent of from right sternocleidomastoid to left sternocleidomastoid, and vertical extent from upper border of thyroid cartilage to suprasternal node. Swelling is not fixed to skin or underlying structure. Getting below the swelling is possible. No thrill, no other palpable swelling in the neck. The bilateral carotid pulsation is palpable but displaced laterally. The trachea is centrally placed. Auscultation, no bruit over the swelling. On CVS examination, S1, S2 is normal with no murmur. CNS conscious and oriented. Respiratory system is bilateral errantry present with no abnormal sound, and per abdomen is soft non-tender. As the 62-year-old male patient presented with a complaint of weight loss 1.5 years ago, associated with the watery diarrhea 1.5 years ago, with incidentally noticed neck swelling since last 1.5 years, which was gradually increased in size and become current size, and also having difficulty in closing the eyelids while sleeping with the redness in the eyes since last 1 year. Patient got medication from private hospital after blood reports, and dose of medication were increased 2 times in the follow-up. On examination, there is approximate 15 by 10 centimeter well-defined butterfly-shaped swelling, diffuse smooth surface, soft to firm swelling in front of the neck, which moves with the deglutition, which is associated with the eye signs. From this, sir, I have my provisional diagnosis of thyrotoxicosis, probably primary, mainly Graves' disease.
Where do you auscultate for bruit and why?
Sir, I will auscultate at the superior pole of the thyroid, because when there is a enlargement of the thyroid, the vascularity is increased mainly at the superior thyroid artery.
No, is that the reason? The vascularity is in of the whole gland. Why
Yes,
near the superior pole? You are auscultating over the superior thyroid artery. Why not over the inferior thyroid artery?
Because sir, superior thyroid artery is enters the thyroid gland from the at the superficial, where is it is more superficial, sir.
Yes, it is more
At entrance.
correct. It is more superficial. That is why you auscultate near the upper pole of the thyroid gland. Why does he have redness of the eyes?
Sir, redness of the eyes is due to, sir, patient having, sir, chronic eye symptoms, protrusion of the eyeball, which, sir, difficulty in closing out. So more of exposure to the atmosphere, which can lead to, sir, redness, sir.
Does he have exophthalmos?
Yes, sir. It is, sir. There is a exophthalmos is present, sir.
How did you evaluate that?
Sir, exophthalmos we can evaluate by, sir, the instrument called, sir, exophthalmometer, sir.
Clinically, you cannot evaluate the exophthalmos?
Clinically, when there is a visible upper and lower sclera, we can call it exophthalmos.
Yes.
And we can see by visible sclera, sir.
And if you examine from the back, can you know?
We are examining from the back, and ask if we examine from the patient sitting, and we are standing behind the patient. If the eyeball is protruding from the, sir, we can visible the eyeball, then it suggests the exophthalmos.
On what? Visible eyeball beyond what?
Sir, upper eyelids. No, sorry.
Sumit, you told the trachea is in the midline. How do you make out the trachea is in the midline?
Sir, we can see the trachea in the midline by, sir, 3-finger test, sir. From sir, by trail sign, sir.
What do you do? What do you do in that?
That is the trail sign, 3-finger test?
That is not the trail sign.
Sir, we kept the middle finger in between, sir, and the other two index fingers, sir, over the sternocleidomastoid head, sir, medial head, sir, and we go lower down, sir. If the middle finger is in the straight line, we can call it, sir, trachea in midlines.
No, you have to dip your finger on the side of the trachea, and then only you can say. It is not that you are just moving in the center part. You have to move your finger in the midline, and then you have to dip on the either side. If it is not dipping on one side, it means it is trachea shifted to that side.
Yes, sir.
Okay, and the trail sign is not on the 3-finger test. Okay, the trail sign is on inspection, that there is something prominent is there. What is that prominence? To say it is trachea shifted to that side?
Prominent sternocleidomastoid.
Yes, prominent sternocleidomastoid. No? So
Yes,
that
sir.
is on inspection. Any other way to know the trachea apart from these 2 ways?
Sir, we can auscultate for the air entry, and we can get cervical neck X-ray.
Right. No, not X-ray. We are not talking the X-ray here, on the clinical. So on inspection, on palpation, and on auscultation, you can know the position of the trachea.
Yeah.
And what Professor Sanjeev Gupta was asking about, where is the inferior thyroid artery? Why you do not auscultate over the lower pole?
Sir, inferior thyroid arteries enter in the thyroid gland from the. It is a deeper structure, sir. It is
Does it come over the inferior thyroid pole or not? Does the inferior thyroid artery comes over the inferior pole or not?
Yes, sir. It is entering through the inferior pole. Yes, sir. But sir,
it doesn't come over the inferior pole. You know, all the 3 vessels which are there over the thyroid, they are the different things. The top one which is there, superior thyroid artery and the superior thyroid vein, they run together on the superior pole.
Yes, sir.
Superior thyroid vein is only on the inferior pole, while the inferior thyroid artery is coming from the side behind the carotid sheath. So usually the site of that is upper 2/3 and the 1/3, lower 1/3 of the thyroid which is there. So it is entering from the side at a deeper level, while the middle thyroid vein is alone here. So all 3 vessels which are there, they have got the different partners with them. Okay.
Yes, sir.
And about the exophthalmos, what Professor Ajay Khanna was asking, when you are looking at the back from the top of the patient, if it is projecting beyond the supraorbital ridge, then you say it is exophthalmos. So clinically you can assess. You don't need the exophthalmometer.
Yes.
What are the other eye signs that you have not mentioned? You mentioned only about the widened palpebral fissure.
Wide palpebral fissure and sir, continuous staring look with infrequent blinking, Stelweck sign, sir. Another eye sign is sir, when there is a lead leg sign, sir. When the upper eyelid is lag behind while ask the patient to look downwards with fixing the head. The another is sir, Joffroy sign, sir.
What is
when
that?
there is absence of forehead wrinkling, sir, while asking the patient to look upwards with fixing the head.
Okay. Then,
sir, one another is a Mobius sign, where if there is a absence of delay in convergence of the eyeball, sir.
How do you test for that?
Sir, first we fix the head of the patient, sir, by put a hand over the head, sir, and ask the patient to look at the distant object, sir. Then that site, sir, we put a pen or pencil in between the site and ask the patient to see the tip of the pen, sir. At that time, the convergence of the eyeball we can assess, sir.
No, you can bring that finger closer to the eyes and you can see whether they are converging or not.
Yes.
So it's not that you put another object. You can put your finger at a distance and then bring it closer. And you can look for the convergence by fixing the head. What is malignant exophthalmos?
Sir, when the exophthalmos changes is occurring severe, sir, when there is a corneal edema, sir, conjunctival chemosis, and due to continuous exposure, the corneal ulceration, sir, which can ultimately lead to, sir, ophthalmoplegia and papilloedema, which is known as the malignant exophthalmos.
And what is the cause for exophthalmos?
Sir, exophthalmos occurs due to the fat deposition and fluid deposition in the retroorbital space, sir.
Mucopolysaccharides.
Mucopolysaccharides, glycosamine, sir. Yes.
And what is responsible for that?
Sir, it is due to, sir, hyaluronic acid and quantity, mainly, sir.
No. I mean the etiological factor. Like if you reverse the thyrotoxicosis, will the
Yes, sir.
exophthalmos improve?
No, sir. Exophthalmos, if thyroidectomy, if radioiodine ablation is given, sir, then exophthalmos even worsen in that condition, sir. And no, it is the irreversible exophthalmos.
Have you heard about EPS? What is EPS?
Exophthalmos producing substances?
Yes. What is that?
Sir, they are.
It is supposed to be an autoantibody. It has an autoimmune mechanism
Yes,
which
sir. They do.
produces exophthalmos.
Yes.
So even if you correct the bring down the thyroxine levels, the exophthalmos will not revert.
Yes.
Do
What
you know
is
in which order
real
the eye
symbol?
signs they come?
Yeah.
Any idea about that? In which order they come? You know, there are so many eye signs which are there. So which is the first sign to appear?
Sir, first sign is first is appears is lead retraction, sir.
The first is
Then
the Stellwag.
Continuous, yes.
Stellwag, है ना?
Yes,
That
sir.
is
Stellwag is, sir, a continuous staring look with infrequent
staring.
blinking, sir.
Yes. So that is the first to appear.
Yes.
Second is the Von Graffes.
Yes, sir. Van Gogh is
Third
lead
is the
leg sign.
Jeffries. And
Yes.
fourth is the Mobius. So in
Yes.
this order they appear. Okay.
Yes.
Have you tested the CNS in your patient? Central nervous system.
Sir, not the detailed examination, but sir, patient is conscious and oriented, sir, with no any anxious look and normal looking patient, sir.
What are the various, you have to, in this patient, you have to work in detail about that. Okay, your patient is a case of a thyrotoxicosis. So there will be so many features of the CNS in this patient. So what are those things you are going to see?
Sir, first we started with the look of the patient, sir. If there is an anxious look of the patient, which sir, there is a fine tremors, sir. Yeah, and
see the fine tremors?
Yes, sir. No tremors at present, sir. I have mentioned it.
No. How do you see the tremors?
Sir, I asked the patient to extend the both hands, both the upper limb, sir, with sir apart the fingers, sir, and sir mid in extended position, sir.
Then
and we can look for the sir fine tremors. Sir.
How will you look for that?
Sir, I put the piece of paper over the sir hand, sir, and we look for the.
So which size of the piece of paper you will put? A4?
A4 size paper to both.
Don't put A4 size. No, A4 is too big for that. Huh?
Okay, sir.
So you have to put either the B5 which is there. So it will be only coming in the central part of the hand there.
Hand. Okay.
And then you must make sure, what you have to make sure before you put the paper over the hand? In the room, what will be there?
Sir, there is a closed window and no air circulation.
So at least, if you have got the AC, it is okay. But if there is a fan is there, okay, so fan has to be off. Then only you can test for that. So this is one thing in the CNS. The tremors is the part of the CNS examination. What else the CNS examination you have tested in this patient?
When the sir patient having sir any psychiatric features like
examination.
Yeah.
Did you tell the muscle power here?
Yes, sir. We look for the sir myopathy, muscle weakness, or fatigability.
In this patient,
yes,
you have
myopathy and
so which myopathy you are going to look?
Proximal myopathy, sir.
So how will you look for that proximal myopathy?
Yes, sir.
How will you look for that proximal myopathy?
Sir, we ask the patient to if he has a difficulty in his routine works like, sir,
You are examining.
co-
Okay. You are
Yes.
examining the patient for the proximal myopathy. Now tell how you are going to examine it.
If we are we assess the power of we should assess the power of the muscle, sir, against the resistance, sir. If we
Which muscle
we
you
are
are going to,
what-
which
we,
muscle you are going
which
to?
sir, I will going to see, sir, bicep in the upper limb, and sir, in the lower limb, sir, there is quadriceps muscle, sir, for proximal myopathy.
So how will you test that? You have not told me how you are going to test it.
Sir,
Okay, let me tell you, because you do not know.
Yes.
Ask the patient to squat and ask him to get up.
Get up, yes.
Won't be able to get up without the support. That is the typical proximal myopathy which is there, right?
Yes.
Then you have to check for the tendon reflexes. Very important. In a patient with thyrotoxicosis, you are not checked for the tendon reflexes.
What will happen? What will happen to the tendon reflexes?
Sir.
They'll be brisk.
Risk tendon, yes.
Brisk tendon.
Exaggerated.
Exaggerated, yes.
Yes.
What is pretibial myxedema? Have you mentioned in this patient?
Sir, I mentioned, sir, there is no clubbing cyanosis and peripheral no limb changes, sir. Pretibial eczema is, sir, there is a coarse thickening of the skin, sir, of the, sir, bilateral lower limb, sir, in the ankle and heel region, sir, which can extend up to the knee, sir.
Edema is due to what?
Sir, it is due to the deposition of the, sir, glycosaminoglycans in the, sir, both subcutaneous plane, sir.
Which is the exact area? It's not in the ankle here, no?
Sir, feet and ankle, sir, and up to extending up to the, sir, up to the knee, sir, leg, sir.
You say shin of the tibia.
Shin of the tibia.
Tell the shin of the tibia. There you will look for the. So is it a feature of a hypo or hyper?
Sir, it is a feature of hyperthyroidism. Particularly, sir. Yes, sir.
All right. Okay.
So how will you proceed?
Sir, as this is the case of, sir, most probably, sir, primary thyrotoxicosis with a grave disease, sir. We can, but sir, this patient already, sir, taken the medication for, sir, 1.5 years and still having a symptom, sir. So, sir, we can, sir, go for either, sir, radioiodine ablation or, but here there is a ophthalmopathy, sir. So, surgery is the better option for this patient.
So you are directly going for the surgery without doing any investigation for this patient?
No, sir. We first, sir, first do, sir, the thyroid function test, sir. Sir, we can also give the, sir, trial of, sir, increasing dose of the antithyroid medication as the patient is came with the, sir, lesser dose, sir. We can extend, we can increase the dose of the medication, sir, first.
Now, which thyroid function you are going to do?
Sir, we see the, sir, serum TSH level, free T3 and free T4 level, sir.
Okay. So
And sir,
are
for
you going to
confirming,
do in a patient with a thyroid swelling, are you going to do all the 3 tests? If you are a patient who is having a thyroid problem,
yes, sir.
are you going to do all the 3 tests at the first go?
Sir, first we can assess the, sir, TSH. We can for screening of the thyroid, sir. It is,
Okay. Now you are given a choice to carry out one investigation, out of all those total and free T3 and T4, which one you will do?
Sir, I will go for TSH, serum TSH level.
And apart from the TSH, TSH is the screening modality,
Yes,
and
sir.
then out of all those 4 hormones which are there,
the next one is, sir, free T4 levels.
Free T4, right? Okay, you are right, you will do a free T4 for that, yeah.
Yes, sir.
Then other
Any
investigation.
place for thyroid scan and all? Radioactive.
Yes, sir.
Any radioactive iodine uptake study? Is there any role for that in this case?
Sir, as is it is clinically, sir, apparent case of sir Graves disease, sir. So and we can if thyroid function test also suggesting us the same picture, sir. It is not necessary to do the sir thyroid scan for this patient.
When will you do that? Patient
Sir,
right.
thyroid patient, if we are if there is a if there is a solitary toxic nodule is there in the thyroid, or we have suspecting in the case of there is a low TSH level with a toxic nodule, and then the other one is then in the case of the ectopic thyroid nodule or retrosternal extension, or we can look for the secondaries in the case of operated case of thyroidectomy in malignancy, sir.
No, more than that, in the hyperthyroid phase of thyroiditis, the differentiate GD from early phase of thyroiditis, where there will be hyperthyroidism. No.
Oh, sir, I don't understand, sir.
The thyroid
Patient.
radioactive and uptake tests, you can do that when you suspect thyroiditis sometimes. The early phase of thyroiditis will have hyperthyroidism, right?
Okay, sir. Yes, sir.
Differentiate that, you can do that.
Yes, sir. If we are want to rule out the other autoimmune thyroiditis like Hashimoto's.
Hashimoto's, you generally have hypothyroidism, not hyperthyroidism.
The initial phase of sir,
Yes.
in the initial phase when we are diagnosis.
What is quadruple testing in the thyroid?
Triple test.
Like in the breast, we have the triple test. What is quadruple test in the thyroid?
Sir, don't know, sir.
Okay, quadruple test is that you do the clinical, as in the triple test you do in that. You do
Clinical. Okay,
you
sir.
do the cytological examination, and
Yes, sir.
is that you are doing the thyroid
Yes.
test. Okay.
Oh,
But
yes.
some people say that you can also do the genetic studies in that.
Yes,
In
sir.
case of the thyroid problems, you can do the genetic study that is taken as a quadruple test. But
Yes.
commonly, quadruple test is the clinical testing or the clinical history and the examination, thyroid
Yes.
function test, imaging, and then
Yes.
the cytology.
Yes,
Okay.
sir.
So in this patient, if you do the imaging study in this patient, what thing you are going to get in your patient? Or has
Sir,
it
in the sir ultrasonography, sir, there is a diffuse enlargement of the gland associated with sir increased vascularity is seen on the sir ultrasonography pictures.
has it been done in your patient?
Yes, sir.
Okay, can you just show that?
Yes, sir.
Okay.
Sir, both lobes of isthmus and thyroid gland appears bulky in size with altered echo texture with raised vascularity, sir, which shows the foci of the calcification and few cystic areas. Sir. Possibility of hyperthyroidism, Graves disease more likely. Sir.
So when this ultrasound was done, what was the frequency of the probe which was used?
That I don't know, sir.
When you do abdominal ultrasound, you know what is the frequency of the probe?
No, sir.
Okay, it is around 3.5 to 5 megahertz in the case of abdomen.
Yes,
When
sir.
you do the TVS or you do the truss, it is 7.5 megahertz.
Yes, sir.
Do for the breast and the thyroid, it is 10 to 12 megahertz. When
Yes,
you
sir.
go for the intraoperative or the endo ultrasound, it is 15 megahertz. Okay.
Okay.
So
Yes, sir.
higher the frequency, what
Low,
happens?
superficial structure can be seen with higher frequency.
Yeah, lesser the penetration, better the resolution.
Yes.
Okay. So when you're doing the thyroid one, you are going to use the 10 to 12 megahertz probe for that. Okay.
Yes.
Then anything else has been done in this patient?
Sir, we get done,
You
sir.
do FNAC in this patient or not?
Sir, FNAC is not mandatory in this patient, sir, because sir,
Yeah, it is probably not required in your patient.
Not required. Yes,
Because
sir.
it can be even harmful also. In what way
Yes,
it can
sir.
be harmful?
Sir, as there is it can lead to the hemorrhage in the gland, sir, because
Very
already
likely
having
have
increased
hemorrhage.
vascular.
Yes. It's a very vascular gland, so there is very high chance of having the hemorrhage in that. So
Yes.
FNAC is probably not indicated in your patient.
Generally, it is not indicated. Is there any place for FNAC in this? In this case, suppose if you got a clinically hard nodule and ultrasound wise, there is a suspicion of malignancy.
Yes, sir.
In that situation, you can go for
FNAC.
ultrasound guided FNAC,
Yes, sir.
getting that suspicious nodule. Otherwise, generally in a diffuse enlargement, as sir said, there is a high chance of vascularity and hemorrhage. You should, FNAC is not mandatory. Right?
Yes.
What other X-ray will you do in this patient? Other than the ultra, what other imaging study will you do?
Sir, if we want to, sir, see the another extension of the thyroid gland, then sir, we can go for the CECT thorax or MR or
No,
the
clinically, there is no evidence that
no,
there is
no,
any
sir.
retrospective extension.
In this case, sir, USG suggest and even clinically no retrosternal extension in the clinical examination.
No, for the operative management, any other X-ray you would want to do?
For the operative management, sir, we can go for the cervical neck X-ray, sir, AP and lateral.
Why? What for?
Sir, we to assess the cervical spine in this patient and sir, the position of
Cervical spine. There's nothing wrong with the cervical spine. What do you want to assess when you do the X-ray neck, AP and lateral? What do you want to assess? It is a very important investigation. The anesthetist won't give a clearance in the pre-anesthetic checkup without the X-ray neck. Why? You mentioned it in your clinical examination about the position of the trachea.
yes, sir, midline for the changes of position of trachea, sir.
So, what? Why do you take two views? What does it tell you? The X-ray neck,
We cease
AP and
compression.
lateral will tell you what about the trachea? Which view will tell you what? See, the lateral view will tell you about the deviation, which side it is shifted. And the AP view will tell you about the angulation of the trachea.
Yes,
It
sir.
is very important in long-standing goiters because then the anesthetist knows if there is angulation of the trachea that there might be a difficult intubation.
Yes, sir.
So he is prepared for that eventuality.
Yes, sir.
So that is very important pre-operative investigation.
Yes, sir.
You said that you will manage this patient operatively. How would you prepare this patient for surgery? What are the pre-operative preparation in a thyrotoxic patient?
Sir, it is necessary to make the patient euthyroid before the surgery, sir. We can start the anti-thyroid drugs, sir, to the higher doses, sir. And then, sir, we also put the patient on beta blockers, sir.
Why?
Sir, as in the condition of hyperthyroid, there is supersensitization of the sympathetic receptor, sir. Sir, so which is, sir, we have to so we put the patient in the beta blocker, sir.
When? How long? For how long?
Sir, we start the beta block. We can after the surgery up to the 7 days, sir. Post operative, up to 7 days beta blocker is continue.
Why? Why?
Because sir, half life of thyroid hormones, sir, is 6 to 7 days.
Yes. So you have to continue the propranolol or whatever beta blocker. Usually we use propranolol.
Yes.
It is started about 10 to 14 days prior to the surgery.
Yes, sir.
At least 7 days is minimum, and then you continue to 5 to 7 days after the surgery.
Yes.
Okay. Anything else in pre-operative preparation?
Sir, we can use the Lugol's iodine, sir. But
what does it do?
So Lugol's iodine causes, sir, prevent the release of thyroid hormone and causes the thyroid constipation, sir.
It decreases the vascularity.
Decrease the vascularity and make the gland firm, sir. So it is easy to handle while surgery.
Okay.
So we are directly planning for surgery, no other treatment modalities.
Sir, we can, sir, if the anti-thyroid drugs dose is not controlling, then, sir, we can go for the surgery.
Is there any place for radioactive iodine therapy?
Sir, as in this patient, there is ophthalmopathy, sir, is present, sir. It can worsen, radioactive iodine can worsen the ophthalmopathy, sir.
So how long it will take for the anti-thyroid drugs to make it euthyroid? Minimum period of?
Minimum period of, sir, we should give, sir, 6 to 8 weeks, sir.
Okay. So any other investigations you are going to do? You have done the X-ray of the neck in this patient. You have done your blood profile. Any other investigation you want to do before you go for plan for the surgery?
Sir, we can go for the, sir, indirect laryngoscopy for the vocal cord examination of the patient.
What do you understand by indirect laryngoscopy?
Sir, indirect laryngoscopy, sir, I mean the direct laryngoscopy is when we done intubation, sir. There is direct visualization of the larynx, sir. Whereas the indirect laryngoscopy, sir, there is a mirror which can project the larynx. We can insert the laryngoscopic mirror, sir, through the oral cavity, and
where do you keep that mirror?
sir,
where do you keep that mirror? Who does
Sir,
that?
Yes,
usually indirect laryngoscopy is done by whom?
ENT department.
So where do they keep that angled mirror?
At the posterior pharynx, sir.
Toward the posterior pharynx, near the soft palate, hai na?
Yes, sir.
Near the posterior pharynx, at the soft palate area, and then they can see for that. Nowadays, can we see the larynx by any other means?
Sir, we can go video stroboscopy, sir, for the laryngeal examination.
Fiber optic you can use for that.
Fiber optic video stroboscopy. Yes, sir.
Okay. So now you are planning in this patient and you are the resident of the unit. There are 5 cases surgeon says that I have to operate. 2 lab collies, 1 this patient of the thyroid, and 2 other operations, appendix or something else. How
Yes,
you're
sir.
going to make the list of this?
Sir, I will put the thyroid operation first, sir.
Why you want to keep it as first?
Yes, sir, it is a clean operation, so it is.
Lab collie is also clean. Everyone is clean. But why the first case? Patient has been prepared for the
Sir, patient.
thyrotoxicosis.
Yes, sir. If there is chances of thyrotoxicosis in the during surgery, sir.
Yes, it can precipitate. The patient will be in the operation theater
Yes,
thinking
thyroid storm, sir.
operated, and that is why a very important drug which is used apart from all those drugs is the anxiolytic drugs.
Yes.
Anesthetists, they always advise for the anxiolytic drugs for these patients.
Thank you.
And then they are taken to the theater. And because
Yeah.
the reason for taking as first apart from this is there's a very high chance of having the hemorrhage in these patients.
Yes, sir.
Patients who have been operated. So hemorrhage and the storm which can occur. And that is why you have to observe these patients for a longer time.
Yes, sir.
So they should be kept near the area of the anesthetist. So if
Yes,
there is
sir.
any crisis is there, it should be immediately tackled. And that is why this should be always kept as a first case.
First operation.
Right.
Yes.
Okay. So you have taken this patient for the surgery now. How you are going to prepare your patient for surgery now?
Yes, sir.
Tell that.
Sir, we kept the position in Rose position.
What surgery you are planning? In this patient, what surgery you are planning?
Sir, near total or total thyroidectomy, sir.
Don't say near total. You will always
Go for total thyroidectomy.
total thyroidectomy in this patient. Okay.
Yes, sir.
So you are taking
Sir,
the table. Now,
yes, sir.
you are the resident in charge of that. You
Yes,
have to do everything for that patient.
yes.
Okay.
Sir, we first kept the patient in the Rose position, sir.
What is that Rose position?
Rose position with, sir, there is a sandbag under the shoulders, sir. With the head is 30-degree, neck is a 30-degree extension with head and elevation, sir.
30 degrees little more, na? 30 degrees little more.
Okay.
Okay, around 15 degree. Okay.
Yes, sir.
Neck will be extended or flexed?
Sir, extended.
Extended. Yes, you are right. Na? It will be extended.
Yes, sir.
And underneath the head, something will be put.
That's a ring. Ring is placed under the head, sir.
What is that called as? That ring is called as ring donut.
Donut.
Ring donut. Yes, sir.
Donut.
What is the idea? Why do you do it? Why do you place the donut?
Sir, at the parietal.
No, you place it in the occiput, but why do you
Occiput.
do it? To stabilize the head.
Yes, sir.
So once you put a sandbag in between the shoulder blades and you extend the neck,
Yes.
then the head will shift to one side. So to stabilize it, you will put a donut.
No.
A
Yes, sir.
ring. Then what else? Carry on.
What else in the
Yes.
position?
And sir, we kept both the hands along the side of the body, sir.
Right. Why you do that? Why you
Sir,
do that?
sir, we have to open, sir. If a hand are extended, sir, there is a difficulty operating field.
Technical problem is there.
Technical problems. Yes, sir.
Move from this place to other place, and that is why you do not want the hand to be coming between.
Yes, sir.
Right. Then, how you are going to drape your patient?
Sir, we have, sir, crossed cross draping, sir, like from the both side in triangular shape. Sir, name. Sir, we put the, sir, one drape from, sir, from the, sir, one side of the neck, sir.
You use a double towel. You use a
Double towel draping, sir. Yes, sir. Two sides, sir.
Double towel.
Yes, sir.
Okay. Now proceed with the incision now.
Sir, incision is, sir, along the, sir, skin crease, horizontal skin crease incision, sir. 1 to 2 centimeter above the suprasternal notch, sir. And then, sir, we cut the skin and
decide that, there are many creases which are there. In the neck,
Yes.
there are several creases. So how do you decide that which crease has to be used?
sir, we generally, sir, 1 to 2 centimeter above the suprasternal notch, we, sir, mark the incision, sir.
Yes, that is okay. It is 1 to 2 centimeter above that, but it depends on the size of the gland which is.
Yes, sir.
Okay, if the bigger the gland is there and it is going more proximally, means toward the head area, then you have to make your incision slightly at a higher
Slightly
position.
up. Yes, sir.
Right. Then after making a skin incision,
Sir, then skin cut and, sir, platysma cut, and then, sir, subplatysmal plane is flap is raised, sir.
how many platysma are there?
Platysma, sir, one platysma layer.
No, how many platysma muscles are there?
Yeah.
There are
How
two
many
platysma.
number?
Not one.
Yes, sir.
And where it is joining? They join in the midline.
Midline, sir.
Yeah, so in the midline, if you see carefully, there
Yes,
is no
sir.
platysma in that area, only the fat is there.
Yes, sir.
Okay, so when you are suturing the platysma, you will find that there is no platysma in the midline is there.
Yes, sir.
Two platysma. Okay, then what you do?
Sir, then we raise the subplatysmal flap, sir. Superiorly up to the the upper border of thyroid cartilage, and inferiorly up to the suprasternal node, sir.
At what level do you cut the platysma? Same as the skin incision or different?
No, sir. We cut the platysma at the upper level, sir.
Slightly
prevent the
higher than the skin incision.
Yes, sir. To prevent the injury to answer cervicals.
So you raise the flap, then go on, carry on.
Sir, when raise the plant, then muscle is sir splitted, sir. If the large thyroid enlargement, sir, so we have to cut the step muscle, sir. And after
Where
that,
you
sir.
cut the stap muscles?
Yes, sir.
Where you will cut the stap muscles?
Sir, we cut the step muscle at the higher level than the skin incision, sir.
Reason?
So to prevent injury to answer cervicalis.
Because it comes down and hooks there and then supply.
Yes,
that is why it is cut at a higher level.
Yes, sir.
Okay. Then
we start the dissection, sir. First, we try to dissect the laterally, sir. To ligate. First, we have to go for the middle thyroid vein, sir. Middle thyroid veins are first dissected and ligated, sir. Then, sir, superior pole dissection is get done, sir. The superior thyroid vessels and superior laryngeal nerve is identified, sir. And superior thyroid vessels are ligated near the glands.
which branch comes there of the nerve?
Sir, external laryngeal nerve. External branch of superior laryngeal nerve.
External branch of superior laryngeal nerve. Okay, right.
Yes, sir. Then, sir, we take the thyroid, pull the thyroid supralaterally, sir, and start the dissection, sir, posterior-laterally, sir. Then, sir, we go to the inferior pole, sir, and try to ligate the inferior thyroid arteries, sir. Mainly the capsular branches, sir, near the gland. And first we identify the recurrent laryngeal nerve, and then we ligate the inferior thyroid artery.
No, you do not ligate the inferior thyroid artery. Okay, that concept has gone.
Yes,
because if you ligate the inferior thyroid artery, what will happen?
Sir, main capsular branches. Sir.
Capsular. So that is called a capsular dissection. Okay.
Yes, sir.
Okay, so it is not the ligation of the main trunk of that, because if you ligate the main trunk,
the loss of the inferior parathyroid supply is lost. Both parathyroid supply is lost.
Will go. So you do not want to ligate the main trunk there. So that is why you are only doing a capsular dissection.
Yes, sir.
Okay, looking for the parathyroid and looking also for the recurrent laryngeal nerve.
Yes.
Okay.
Why it is much importance given to middle thyroid vein identification and ligation? You said first identification.
Yes, sir. Middle, as it is a short branch and it is and stout branch, sir, it can easily tear while dissecting the thyroid gland, sir.
Short and stumpy vein directly enters where?
IJV, sir. Inferior internal jugular.
Okay. Now you have.
Yeah. Where will you locate the superior parathyroid and inferior parathyroid?
Sir, the
superior parathyroid. Which one will have a constant location?
So superior parathyroid have a constant location, sir.
Inferior?
Inferior thyroid, sir, mostly along with the infralateral to the in the infralateral lobe, sir. But it can deviate as it is come down along with the thymus, sir. So it can go variable locations.
Why it is going for ectopic locations, inferior?
Because, sir, it is arising from the third pharyngeal pouch along with the thymic thymus, sir. And they have a descent down while, sir, embryogenesis, sir.
How many parathyroids are in the body?
So total 4 parathyroids, 2 superior and 2 inferior parathyroids.
All will have 4? Or it is known for anomalies in number also?
Don't know, sir.
It is known for anomalies. There may be 2, there may be 3.
Yes.
Surprisingly, the maximum recorded number in a human body is 13.
Yeah. Yes. Okay.
Right?
Yes, sir.
Okay, tell me what is thyrotoxic crisis?
Thyroid storm, sir. It is, sir, exacerbation of, sir, features of thyrotoxicosis, sir. Which is present, which is a life-threatening condition, sir. Patient can be, sir, present with the, sir, severe fever, sir, dehydration with, sir, agitation and stuporous look, sir, and palpitation. It can lead to also the arrhythmia, sir, and heart condition of heart failure, sir, with breathlessness.
Hyperpyrexia.
Hyperpyrexia, yes.
How will you manage?
Sir, the first, the main aim is, sir, to stabilize the patient, sir. We put the, sir, patient IV lines and started the, sir, aggressive rehydration therapy, sir. Then, sir, the cold sponging for the hyperpyrexia, sir. In the drugs, sir, we're starting, sir, corticosteroid given by IV line, sir. Then, sir, IV beta blockers, IV propranolol is given, sir, to manage the, sir, cardiac symptoms, sir, and palpitation and arrhythmia, sir. Along with them, sir, we can go, sir, IV propyl thiouresil in this patient.
Any other complications you will encounter in thyroid surgery?
During thyroid surgery, sir, there is a injury to the, sir, recurrent laryngeal nerves and superior laryngeal nerve can occur, sir.
Then
There
injury
is,
to
sir,
parathyroid.
injury to, yes, sir, accidental removal of parathyroid gland can occur, sir.
So how do you identify the parathyroids?
Sir, an identification, it's a, sir, fat-like, brown, yellowish fat-like structure, sir. When which on touch, sir, changes the color to, sir, like pink.
Pink.
Venous hues.
Now, in case if you have removed a tissue and you are not sure whether it is a parathyroid or it is
We
something.
should put in, sir, water, sir.
Mhm.
If it is fat, then it's, sir, floats, sir, and parathyroid is sinks.
It will sink to the bottom.
And bottom is in between.
It will not sink to the bottom. You know, it will be
In between, sir. In between those waters.
But if it sinks to the bottom, probably that is the enlarged parathyroid. Like
Yes, sir.
parathyroid adenoma.
Adenoma.
Okay,
Yes.
then it will sink to the bottom there. You know?
Yes, sir.
Normal parathyroid will be in between, while fat will float.
Yes.
Okay. You know any way to identify the parathyroid at the time of the operation? If you want to identify, can you give something to the patient by which you can identify this is a parathyroid? Nowadays, that is dye is used in almost everything now. You know, what is that?
The systemic scans?
No, that is a scan. You know? At the time of the operation, you can give it IV. Endocyanin green.
Green.
Endocyanin green. Yes, sir.
Green.
ICG.
Or
Yes, sir.
even you can give the methylene blue also.
Methylene. Yes, sir.
Specifically taken by the parathyroid. So these dyes can be used to identify the parathyroids.
Yes.
Okay. So you have done the surgery in this patient and patient has gone to the post-operative room.
Yes.
and you get a call that the patient is having the respiratory problem. So what are the things you think in that patient, and how you are going to manage that?
Sir, first thought is maybe there is a hemorrhage after post-operative hemorrhage after the surgery, sir.
So what is
Which
that
can lead
hemorrhage called as? What is the name of that hemorrhage?
reactionary hemorrhage, sir. Which is which can increase in the size of the hemorrhage, will lead to the compression of the respiratory trachea, and which can lead to the breathlessness.
What will you do?
Sir, immediately, sir, we should open up the suture and taken the patient again to the operative room, sir.
What is the commonest site of leak?
There is
Hemorrhage.
a slippage of slippage of ligature, sir, at the tideway.
Ligature. Inferior, superior, which one?
The superior thyroid.
Huh?
Superior thyroid.
Why? Why superior ligature commonly slips down? It's a direct first branch from external carotid. So
Carotid artery, yes, high pressure.
Okay, if the patient has gone to the ward and
Yes.
then you find there's a hematoma is there, what you will do in the ward and what you will do after that?
Sir, if hematoma is compressing, if it is hematoma is localized and sir patient is stabilized, then sir we can wait. But sir, if it is compressing, sir, suture should be open, sir.
So you are going to all the sutures in the ward, or you are sutured in this patient the strap muscles, you have sutured the platysma, and you have sutured the skin.
Yes, sir.
What sutures you are going to remove in the ward, and what sutures you are going to immediately shift the patient to the OT and then remove that?
Sir, at the ward level, sir, we should open the sutures up to the skin and platysma, sir.
So do not open the suture of the strap muscles in the ward.
Yes, sir.
Okay, because otherwise there will be torrential bleed will be there.
Muscle bleed can, yes, sir.
So you can just give a time for few minutes for that by the time you shift the patient to the operation theater to expand the neck. And that is probably you will get some space in that time. And that is why you remove only the platysma and the skin sutures in the wall and shift the patient to the operation theater, and then you remove the strap sutures which you have put there.
Yes, sir.
When do you get the patient the hypocalcemia in these patients?
Sir, hypocalcemia can precipitate after, sir, 3 to 5 days after the
3 to 5 days is a little longer, is it? In about 48 hours time, in about 48 hours time. And what is the first sign of the hypocalcemia?
Sir, there is a facial twitching and sir carpopedal spasm, sir.
Perioral numbness.
The perioral with the patient feeling perioral numbness.
Perioral numbness is the first.
Yes, sir.
Then what you will do if you find this? If the patient complains of perioral numbness, then what you do?
Sir, we can get the serum calcium level done, sir. If it is sir less than it, then we can give sir IV calcium with oral calcium tablets, sir. And if it we can sir and if it more than it, sir, we can go for sir oral tablet calcium and vitamin D3.
How much calcium will you give? What type of calcium? Calcium gluconate?
Calcium gluconate.
Chloride?
IV calcium gluconate.
How much?
And oral calcium
will you
carbonate. Yes, sir.
This is the precaution that you take when you give IV calcium gluconate. How much do you give and how do you give? It has to be given slow.
Yes,
10
sir.
ml of calcium gluconate given slowly intravenously over a period of 10 to 10 minutes
10 minutes. Yes.
Do not give it as
with cardiac monitoring.
Yes.
6 ampules to be dissolved in 540 ml of saline.
Okay.
And it should be given as a slow infusion, right?
Yes.
You know, when you're taking the blood sample for the calcium, what special thing has to be done?
So,
You know, you ask your intern or your first year that go and take out the blood for that. What
Yes, sir.
advice you will give to him? That he
Don't-
should use the tourniquet.
don't-
He
Okay.
should not use the tourniquet.
Yes.
Use the tourniquet, you will get the fast report of the calcium. No?
Yes, sir. Yes, sir.
Right. Now, how will you identify the recurrent laryngeal nerve palsy which has occurred? How will you identify that?
Sir, recurrent laryngeal palsy can cause, sir, the paralysis of the laryngeal muscle, sir, sir, a lower sensory supply of the sir pharynx, sir. So there is a patient with a sir change in the voice, sir. There is a patient having harshness of the voice, sir, after recurrent laryngeal nerve damage.
So what is the chance of having the temporary paresis of the recurrent laryngeal nerve and the permanent paresis of the recurrent laryngeal in a case of a total thyroidectomy?
Percentage, sir,
The majority of the time, it is never a permanent.
never transient. Yes, sir.
Majority of the time, it is a temporary. And
Okay.
this will recover as the time passes.
Yes, sir.
Probably it is only 1 to 2%, even less than that, that it will be a permanent recurrent laryngeal palsy will be there.
Yes, sir.
Okay. Dr. Kanagal, can we stop now?
Yes, sir.
Yeah.
Definitely, sir. Definitely. We'll allow Smith to clarify if he has any doubts. He has been, I think he has prepared hard. He was given a week's time and sir has prepared him very well. Credits to the standards set by the BJ Medical College staff and faculty. Smith, do you have any questions now that you have studied in more than 2 or 3 textbooks? The way you answer, I could appreciate that. So
Thank you, sir.
you would have developed your own thoughts or you would have had more questions after reading it. By reading more, you end up having more questions only. People tell you get clarity, but then you are going into the next level of learning that you understand the intricacies of going to the research level, telling what are the still unanswered questions which are in the upper level of learning. So I'm sure you would have had more questions. What question do you have as number 1 and 2 with the national faculty here? You can clarify yourself.
Sir, at present, sir, not questions at my mind, sir.
Okay, good. I think you are tired. So, Marudu sir, Kanna sir,
Yeah, but anyway, he
Sanjeev sir.
presented well.
Yes, sir.
He is good.
Thank you very much, Smith. Kanna sir, thank you very much for getting Sanjeev sir. Marudu sir, thank you for joining in the last moment on a very short notice.
Thank you.
Thank you. Sanjeev sir, are you there, sir? Gupta sir?
Yes,
I
got
think
it.
sir has left. I think sir is there only. I think Sanjeev sir, thank you very much. I think we have one more week to go prior to the ASICON. So next week there will be a candidate that will be a vascular disease, peripheral vascular disease week. Arterial disease is presented by a student from AIMS Rishikesh. Venous disease is yet to get confirmed. We'll be shortly confirming. So the next week will be a vascular week. And then we do not have one session during the National ASICON. So subsequent week, we'll get to meet again. So faculty, students, thank you very much for joining this Friday. There have been some issues with the faculty because all the faculty could not join today. So we had to double up and I thank all the faculty for allowing us to conduct the session without any problem. Thank you very much. Sir, Kanna sir, which date are you coming to ASICON, sir?
I'll be reaching on 13th.
Okay, so what time, sir? Should we have a quick meeting of our faculty one evening or one dinner, sir?
We can keep it on the 15th if we like, 15th.
15th evening we'll keep, sir.
Yeah, 15th evening we can keep, yeah.
Okay, sir. Where are you put up, sir?
I'll be in the Dolphin.
Okay, no problem, sir. I will fix up a common venue and arrange a vehicle to carry all of us, sir, together. We'll catch up for a dinner or a quick coffee and then we'll take it further, sir.
Sure. Yeah.
Thank you, sir. Thank you very much.
Thank you so much.
Thank you, Alex.
Can we call it close, sir?
Yes.
Yeah, please, yeah.
Thank you, sir. Thank you very much, sir. Good night, sir.